All right, let's go ahead and get started. Hello, everyone, and welcome to the September 2023 UCLA Tarjan Center Distinguished Lecture Series. I am Dr. Jasper Estevio, Director of Training for the Tarjan Center, and it's my pleasure to be here with you all today. In addition to being our first lecture of the 2023 to 2024 academic year, today marks our inaugural Dr. Andrew Russell Memorial Lecture. We have a few special guests with us today to help commemorate Dr. Russell's work. Before we get started, a few reminders. We offer live Spanish interpretation, and you can click on the interpretation button, which looks like a globe at the bottom of your Zoom toolbar, and select Spanish for interpretation. If there are any questions during the talk, I will respond to them and translate them for you. Please also enter your questions for our speaker into the Q&A function, and we'll facilitate discussion at the end of the presentation. After today's lecture, please also be sure to complete our evaluation survey. We love to hear from our audience what topics you're interested in and what we can do to better serve the needs of the Tarjan community. The link to the evaluation survey will be sent in the chat today, as well as in a follow-up email sent out tomorrow. I'd first like to introduce Dr. Olivia Rayner, Director Emerita of the Tarjan Center. Welcome, Olivia.
Good morning. Thank you for joining us all today for the first annual memorial lecture in honor of Dr. Andrew Russell. Drew and I were co-directors of the UCLA Tarjan Center for 10 years between 2000 and 2010. Two words immediately come to mind as I think about Drew. They are kind and compassionate. He was not just a colleague, he was my friend, mentor, and inspiration to all. His dedication and unwavering commitment to individuals with developmental disabilities and their families leaves an indelible mark on our hearts and the fellows and trainees whose lives he touched as a psychiatrist, teacher, and mentor. Drew worked to ensure that people with disabilities have access to quality and accessible mental health services. His legacy lives on in the knowledge he imparted, the skills he nurtured, and the values instilled in each of us. How fitting that today we have the privilege of not only remembering Drew, but also carrying forward his vision, ideas, and contributions. It is in this spirit we have organized this lecture in his memory to celebrate the incredible person that he was and ensure that his legacy lives on. I have the privilege of introducing Drew's son, Dr. Doug Russell, who is also a child and adolescent psychiatrist coming to us today from the University of Washington and Seattle Children's Hospital. Doug will share some additional thoughts about his father's work and legacy. Doug, I'll turn this over to you now.
All right, thank you so much, Dr. Rayner. I can't tell you what a pleasure it is to be here today to help give some context to my father's life and work and to help inaugurate this memorial lecture series. As Dr. Rayner said, I'm a child and adolescent psychiatrist like my father. So I'm coming to you from Seattle, Washington. And I know a lot of you, or there's probably a bunch of you on this call that knew my father. He directed the Tarjan Center, as Dr. Rayner said, or co-directed it with Dr. Rayner for a decade. For those of you that didn't know my dad, I'm here to provide a little bit of information about who he was, both personally and professionally. So he was born in Berkeley. His parents were both educators. So his dad had a PhD in education and was a pioneer in modern reading science. His mother was a lecturer at Berkeley in the speech department. He's a sage hen, so he graduated from Pomona College in 1966, and then went to medical school at University of Colorado, and then did his adult psychiatry and child and adolescent psychiatry fellowship at UCLA. And, you know, in terms of his legacy, I think, in addition to some work in early childhood schizophrenia, and of course all his the teaching and mentorship he did over the years, he was on faculty at UCLA for 40 years. It was his academic home for his entire career. I think it is his work with patients with neurodevelopmental disabilities and their families that really, I think, was the biggest and most important aspect of his legacy. And he started work at UCLA on faculty as the ward psychiatrist on 6 West, which is a specialized unit for developmentally disabled adolescents. And at the time, he was really one of the few people in the country that had this expertise. Of course, he made it part of his life's work. I mean, he received a lot of awards over the years, but I think the one that was most special to him was the ACAP George Tarjan Award for Contributions in Developmental Disabilities. He was really proud of this work and what he accomplished. On a personal side, when a parent dies, you're in this just incredible position of hearing from peers and colleagues, about your parent. As Dr. Rayner mentioned, there are a few words about my dad that just came up again and again from people that knew him and worked with him. His kindness, his compassionate nature, generous, thoughtful, and he was all those things. And he was a great dad too. There were very few times actually that I saw him lose his temper, but I'm going to tell you about one. I was 10 years old. This was at the dinner table. And at that time, the nomenclature of around neurodevelopmental disabilities and cognitive disabilities, we're still using the term mental retardation. Intellectual disability hadn't come around yet. For those of you that were around in the 1980s, the R word was a bit of a slur on the playground, and when I was 10, I made the mistake of using that word at the dinner table. I directed it towards my brother, who I think is in the audience today. And boy, that was one of those times where, I really saw my father get mad, and it made a big impression on me. He really saw the humanity in everybody, regardless of ability. For that reason and a whole bunch of other reasons, of course, he remains a model for me. So with that, I just would like to extend my gratitude to Dr. Rayner, to Dr. Laugesen, to Jasper and the rest of the Tarjan Center team for honoring my father in this way. I'm really looking forward, Dr. Shore, to your talk today. Thank you.
Thank you so much, Dr. Russell, for being here with us today and for helping us start to commemorate your father's legacy. I know that he has been very foundational in the work that we do, and we hope to be able to continue to carry on his legacy through our lecture series. All right, and with that, I will introduce our speaker, Dr. Stephen Shore. Diagnosed with atypical development and strong autistic tendencies and too sick for outpatient treatment, Dr. Shore was recommended for institutionalization. Non-speaking until age 4, and with much support from his parents, teachers, wife, and others, Stephen is now a full-time professor at Adelphi University and adjunct at the NYU Steinhardt School of Culture, Education, and Human Development, focusing on aligning best practice in supporting autistic people to lead fulfilling and productive lives. In addition to working with children and talking about life on the autism spectrum, Stephen is an internationally renowned educator, consultant, and author on lifespan issues pertinent to education, relationships, employment, and self-advocacy. His most recent book, College for Students with Disabilities, combines personal stories and research for promoting success in higher education. a current board member of Autism Speaks, the Organization for Autism Research, American Occupational Therapy Foundation, President Emeritus of the Asperger Autism Network, and advisory board member of the Autism Society. Dr. Shore also serves on the boards of numerous other autism-related organizations. Please join me in welcoming our speaker, Dr. Stephen Shore.
Well, thank you very much. It's a pleasure to be with you and for during or at such an important event. I'm honored to be with all of you. So here we're. I'm going to set up the screen first. There we go. And we're on our way. So before we begin, I got all the disclaimers and acknowledgements. The work here is funded by PCORI with the goal of meaningfully including autistic stakeholders and identifying priorities and methods to support patient-centered outcomes research in collaboration with autistic people. The views are the authors, they're mine, not necessarily of PCORI. So beginning with what is participatory research? And we're going to look also at what are the implications of authentic engagement of autistic people have for the reliability and validity in autism research. What are some key factors in indicating that we're doing this successfully? And in what ways can participatory research be helpful in determining health priorities for autistic individuals? A real luminary in this area of research is Christina Nicolaitis. I encourage you to click on her presentation that's on YouTube, where she focuses on defining what participatory research is. And it means involving the community. People who tend not to be academic, yet have an important and vital contributions to make to our research. And it involves the equal sharing of power in the research. It goes way beyond involving autistic individuals in terms of serving as subjects or perhaps just sitting on an advisory board, but not really being involved in the research itself. It means authentic and meaningful inclusion, and we'll take a look at how that gets done. Properly used, an advisory board can be good, or using Delphi panels. So let's continue on. There we go. So why do we bother to study or involve autistic individuals? And it's because autistic adults, we were found in a research study some years ago by Drexel University to have a shorter lifespan than the general population. And why is that the case? Inherently, there are no physiological reasons that we should have shorter lifespans. And so that leads us towards looking at the social aspects of obtaining medical care. I use identity first language because most adults on the autism spectrum who have the capacity to think about these things and to communicate about them, we identify with being autistic. We don't think of it as bad. It's just something that is. And we tend to have multiple chronic and potentially preventable healthcare needs as compared with other same age adults. Research has been done in this area, health service research, but we have not looked at what the priorities are for autistic people in addressing these barriers for care. Barriers that many people won't think about, such as accessing care. What is involved in accessing care? You've got to generally get to care, and that may be inaccessible for autistic people, perhaps due to financial reasons. Most people will think nothing of spending $20 or more on public transportation to get to where they need to go. However, since autistic people have a combined under an unemployment rate of 88%, that could be a real barrier, and that's just one of many. The IAC has identified that only 2% of US funding research on autism is spent in addressing adult outcomes. However, there is a movement afoot to increase funding for autistic involvement in research. So that's a positive. So how did all of this start? It began with my giving a presenting on a panel focused on autistic intelligence at an INSAR conference, International Society for Research on Autism. And after I gave my presentation, I was accosted by an occupational therapist, Teal Benavides to be specific, who started talking to me about the need to research into healthcare for autistic individuals. And this is something we needed to study. And perhaps the two of us could do a survey of health professionals and get some answers as to what was important for autistic individuals. However, we thought it would be much better to ask the autistic community itself. And even better than that, let us find a way to involve autistic individuals. So in doing so, we proposed and was accepted for a $250,000 project award, engagement award from PCORI. And what we did is first we established a lead team, half autistic, half not autistic, just to show that autistic people could also be inclusive and collaborate with non-autistic individuals. And we also established a paid community council of mostly autistic adults and a few other stakeholders to inform and guide the work that we're doing. So how does this get done? Well, in doing so, as part of the award was scientific, and that is to ask the question, what is the most challenging healthcare issue facing autistic individuals? And the other part was studying how do we engage autistic individuals. And in doing so, we developed an engagement and compensation guide for meaningfully involving autistic individuals. And in doing so, we focused on what we call the 4 C's: competence, communication, compensation, and considerations for meaningful autistic involvement. So looking at competence for engaging in engaging autistic individuals. One is that we determined that non-speaking individuals should be treated as if they understand all verbal language. I know many non-speaking autistic individuals who, when provided with other means of communication, usually through an AAC device, they have the same range of intelligence as everybody else. So instead of presuming that the autistic person is unable let's presume that the autistic person is able. So what it requires is turning away from thinking of autism as a series of deficits, disorder, and disability, and turning towards looking at the abilities and asking the question, what can the autistic person do? It involves modifying our language. Instead of dysfunction, let's use difference. So we can still use ASD, autism spectrum difference. And that said, we cannot ignore the often debilitating and very challenging and disabling aspects that do come with autism. And it's our job to figure out how to tear down those barriers that are preventing the person from being successful in interacting with the environment. So it's these differences that may impact the function, but we turn away from the medical model of something that needs to be fixed as the individual is being broken, but more towards what can we do to enable this individual? What modifications do we need to make with the environment and with our thinking that will enable this person to be successful? We work with, as opposed to doing things to, the person on the autism spectrum. Again, we assume the person understands what is being discussed. And as I think about, for example, IEP meetings, where the meeting generally focuses on what the child is not able to do. And when the child happens to be in the room, people are mystified why that child suddenly has a meltdown because of all of this talk, this negative talk, deficit model talk, as opposed to what the person can do. So here's an example. Paul Kotler. Can Paul Kotler communicate? Does he understand his environment? Does he have agency? Does he have a voice? Is this somebody you could talk with?
I like to do anything that allows me to have a clear mind and calm body. Ice skating. Exercise. Yoga. When I skate, I feel calm and safe. More fluid movement is possible. I'm high on having control and it's freeing for me.
My name is Melinda Kotler. What's your name?
Kyle.
Gonna try to have a...
It's gonna be.
How's it going? So how are you feeling today? This is a big day.
It has taken me a long time to accept myself. Some people lack understanding that speaking equates to intelligence. I need people to greatly understand that autism hampers communication. I'm able to communicate all I could speak through typing. I want people to know that I'm looking for knowing a life filled seeming like everyone else, friends, listening to music, a job, life like others have.
Head down. Head up. Head down.
I could absorb things but couldn't show it. When I learned to type, I could finally prove my thinking nature.
Ice.
Ice skating.
And
It was important that others knew I was a thinking, caring person greater than my outward behaviors.
Perseverance is the ability to keep working at something even as your whole body screams to go the other way. Some helpful tools would be my own voice instead of a synthetic one, word prediction, option to speak words or sentences, the ability to save documents with easy retrieval, a visual on the device that would allow me to see when my anxiety is increasing. People lack insight, making having autism a life sentence in prison. I bear responsibility for getting most people to see that people with autism are like each normal person inside.
AT&T and the Ability Lab of New York University introduced Connectability.
So Paul definitely does have a lot to say. And we need to focus on finding ways to one, find these people, and then two, determining ways or figuring out ways for autistic individuals to meaningfully be involved in all aspects of research. So communication is another. We began, when we began, we had a response rate to our emails at about 10%, very low percentage with the community council. We then found this protocol, it's contributed by Alicia Ashkenazi, that minimizes words and focuses on what needs to be done. You read this communication, and within moments, you know exactly what needs to be done and when it is due. And we found this means of communication to be helpful with non-autistic people as well. And that's what that line is up there. What's good for the goose is good for the gander. We found that modifications and adjustments that we make for autistic individuals also tend to be good for everybody else. Compensation is the third C. And just as anybody is compensated for their work, so should autistic individuals, especially autistic individuals, given the high under and unemployment rate. So we made sure that community council members were paid for their expertise at $50 an hour, and in work that's continued and that we're doing now, we've managed to get that up to $100 an hour. One challenge that we face is that this funding can interfere with disability benefits, and this is something that we need to figure out how to address. Considerations. We spent a lot of time making sure that there's trust, respect, and support. Equality of voices is vital. So, for example, we had chosen to use Facebook as a means of communication. And shortly after that time, there was a lot of publicity on privacy, related to privacy violations from Facebook. And the community council said, we don't trust Facebook anymore. And we need to find another way to meet and to exchange our information. And the important thing that Teal and I needed to keep in mind is that it was the community council that was driving the research, and that it was up to us to provide the structure and the guidance so that that research could occur. So as we consider looking at considerations, the community council came up with these 7 points that make sure that autistic people are meaningfully included, ranging from including autistic development individuals in all aspects of research and all the way to consulting and making sure that we understand what autistic priorities for research and system changes are. We also protect and emphasize the importance of this being a safe space for us to do work, and prioritize the mental health of everybody involved. So how did we do this? In setting the priorities, we had 2 large groups, stakeholder meetings, online surveys, face-to-face focus groups, mostly concentrated in the United States and Western Europe, and a little bit of South Pacific and Australia. And what were the results? Mental health interventions and outcomes. So we know that if we had gone to the medical community, something else would have been considered as a priority. Maybe obesity, for example. But here is the autistic community telling us it's access to mental health and supports that is the top priority. And what is interesting to find out is that another group by the name of Autistica was doing similar research in the United Kingdom. We didn't know about each other's work, but we both came up with the same outcome, and that was access to mental health supports. Close behind it was access to healthcare, gender inequalities in diagnosis, treatment, and sexual well-being. And as a result, we had a number of articles published in Autism and elsewhere that you can look at to look at other aspects of mental health for autistic individuals. What are the mental health priorities for guiding research and practice in autism? We asked the question, one question we asked is, if you had $1 million, where would you spend this money? And what came up to the top was quality of life, making sure that people on the autism spectrum have a good quality of life. So as we consider how to best get information from as we do this research, we also had to arrive at a decision-making process. And what we've implemented is this 3-step process as we're setting our priorities. And first we discuss options as a team, and then we assess for permission to proceed, and then we finalize the decision or return to step 1. So how does this look? We discuss the options as a team. Our goal is to get input from the people who are involved, clarify all possible options, eliminate various options, and communication might be done through email or through virtual meetings. So for example, at what age, what is the minimum age that people should be involved? Should we have involved in our research? 11, 12, 13, or 14? So then we assess for permission to proceed. And it was narrowed down to 13 or 14. And then we vote. And there are 4 options. I don't have an opinion. 2 is the favored one. I prefer this option and move forward. We'll have other people who don't prefer it, but it's okay if we move forward. And if we get even 1, 4, I don't prefer this and I'm uncomfortable moving forward with this choice, then we have to back up and we have to go back to the beginning. So again, we want to maximize 2s. If we have a 4, then we discuss with that person individually. It takes longer to do that. It takes more time. And a lot of our work, it took longer than we had expected because of this. However, what we prioritized was to make sure that everybody involved in our research felt heard. And as a result, I believe that we get results that are more valid, they're more reliable, because we have focused on prioritizing the autistic voice in this research. And this just is when we finalize the decision. Again, is the decision finalized, or are we going to have to go back, essentially go back to the drawing board? So what are some next steps? What is happening next? What is happening next, and what we're working on now is we're at the beginning of a comparative effectiveness study on suicide prevention, because we also know that one of the leading causes of death in autistic people is suicide. So something must be done about it. And now Teal and I are the team leads on this large, sprawling 5-year study that will study 2 different approaches for suicide prevention. Which approach is better? This is something that we need to ask. We're in the first year of our study, so we're beginning to train professionals who will be supporting autistic individuals who are in need of this intervention, and we'll be interested to see which approach works the best. We've recently began work on another grant that compares mindfulness-based training with cognitive behavioral therapy. And the question, similarly, what is the best way to, which will be best for autistic individuals? And I suspect what we may find is that maybe one approach will work for a certain set of people and the other approach will work for a different set of people. And this is, I believe, important information that we need to find. Another extension of this research involves the community of people with intellectual disabilities. So a little earlier, I think it was Doug that mentioned his father, who was very humane, had a very humane approach to people with, at that time referred to as mental retardation. So this research focuses on access to medical care for people with intellectual disabilities. And one question that I have for this community that I think will be interesting to find is, how do people with intellectual disabilities like to be referred to as? So for example, we know the autistic community, the majority of autistic people prefer identity first language. There's also a large community of people with hearing impairments who identify with being deaf and are referred to as the deaf community. And so relatedly, what about the community of people with intellectual disabilities? Does this community identify with being intellectually disabled and would prefer identity first language, an intellectually disabled person, or a person with an intellectual disability? And whatever answer this community has is the right answer, because we should be listening to the voices of these individuals that we are studying. So as we continue on, here are some publications that you may want to look into, that you may find interesting. As we disseminate our research, here's a couple of articles. Listening to the Autistic Voice, Mental Health Priorities. We looked at a screenshot of that one. And also another one, Interventions to Address Health Outcomes Amongst Autistic Results. We did a systematic review to see what was out there. and the asset, autistic adults and other stakeholders engaged together, engagement and compensation guide, which is available on the PCORI website for your perusal. We encourage you to download this resource and use it as seen fit. Currently, it's being adapted for the community of people with intellectual disabilities. So it's been a pleasure talking to you about research, community-based participatory action research for focusing on the autistic community and how we can better involve the autistic community in a meaningful way, resulting in increased reliability and validity of the work that we're doing to support autistic individuals, lead fulfilling and productive lives, and to make that the rule rather than the exception. So I think now is a great time for questions.
All right. Well, thank you so much, Dr. Shore, for your presentation and for really outlining some very concrete steps for those of us in the audience, researchers and practitioners, for how to engage the autistic community into the work that they do. I was really appreciative and impressed by the 4 points that were outlined in the engagement and compensation guide: competence, communication, compensation, and considerations. I also love alliteration, so I think that it's a very handy tool for us to incorporate into the work that we do. Some other reflections that I had to get us started, and another reminder for our audience to please type your questions into our Q&A function, into the chat. I'm seeing a couple that are there. But one of my main reflections, Dr. Shore, is your comment at the end about having a meaningful impact with the communities that we work with. And I remember a collaborator several years ago that I had worked with who was very explicit on partnership, because we want to make sure that the work that we're doing is meaningful, but meaningful for who and in what way. Right. And I think that the points that you had made here about partnered research really are aligned with that, and that the meaning that we're making shouldn't be imposed on somebody. We really do need to partner with the communities that we aim to support, and to listen to what their priorities are. I'm just going to take a look at some of our questions that are here. And just to start us off, though, Dr. Shore, in the work that you do, what are some of the barriers, I would say, that you might face in participatory work or in the dissemination of the findings that you have? Are there kind of barriers or things that are impeding next steps, or things that future researchers and clinicians should look out for?
Well, I think one of the biggest barriers that we face relates to presumption of competence. So presuming that the autistic person, and we can extend that to other communities, generalize that too, that the person is not competent. Sticking with the medical model, which is very good for medicine. It's excellent when if you have a heart attack or you break your leg, something's really broken and you need to get that fixed, and you want it fixed fast. But when we're dealing with people with differences, such as autism and others, we need to look at it more socially and be asking the question, what can we do to make lives better for these individuals? And in doing so, as we learn more about people with these differences and as we develop these strategies, we end up making life better for everybody. And in the work that I've done on employment and in education, I've had many supervisors and educators and others as well that there's a common theme where they express the work that they've done in better understanding, supporting, communicating those autistic individuals in their midst has made them a better teacher, supervisor, researcher overall.
I agree. I think that these are not things that are too difficult or that we shouldn't already have in our heads and ways to accommodate. I think that accommodations benefit all of us. And I also am always reminded of the double empathy problem when it comes to autism. And I think that that's very much aligned with what you were saying, Dr. Shore, about this barrier of presumed competence, right? It's not just, oh, this other person or community, they are the ones who are at a deficit. It's both sides, right? And we need to partner together to figure out how we can move forward and to do this more meaningfully.
Yes, and the double empathy problem, Damian Milton, who first identified this, in one of his studies, he came up with some very interesting results, and that was he used the game of telephone with 3 groups, and he measured the amount of distortion from the beginning to the end, where one person tells a story to the next person, who then relays it to the next person, who relays it to the next person, and which group was most accurate? Well, there were 3 groups. There was one group that was all autistic people, another group that was a mix of autistic and non-autistic, and a third group that was just non-autistic people. And what he found is that the least amount of accuracy was with the mixed group, the autistic and non-autistic group. The next level of greater accuracy was with the non-autistic group. The autistic group had the greatest amount of accuracy, maybe due to our literal interpretation of language. So that also shows an area of strength or ability for autistic people. And then the question is, what do we use to promote that ability to lead fulfilling and productive lives?
I know, it's so fascinating to think about it that way and to really use the strengths and the ways that we can use those methods and strategies into either whether it's research or practice, just community-based work. I think that that's a really interesting thought. We're seeing wonderful questions into the Q&A. I think I'm going to start off with this one on partnering with people from under-resourced groups and groups who are typically underrepresented in research, who might be skeptical or fearful of research, capital R research. Some groups have historically experienced research being done to them rather than done with them. Dr. Shore, any additional thoughts or comments on, not just focused on the autistic community, but other under-resourced and I think underrepresented groups?
Oh yeah, well, we need to focus on reaching into these communities, finding out who are the leaders of these underrepresented communities, culturally, social, economic status-wise, and there's so many dimensions. We find people who are excluded from the mainstream of life. And we need to find ways to, one, gain their trust, which is the conventions part of the engagement guide. What can we do to earn the trust of these individuals and make sure that we don't break this trust and make research a safe place and bring about the notion that we're researching with you, but not, you might say, at you.
Absolutely. I think it's so important for us to do more authentic work and more partnered work, because otherwise we're only focusing on such a small group within these communities, and it's not going to be either relevant or generalizable to the broader community. As we know,
Yeah,
it's not
exactly.
it's never a one size fits all.
No, it certainly isn't.
Mhm.
So it's getting to know that community, being culturally relevant. I've done a lot of work in other countries, in the Middle East, for example, and there are some things that we take for granted as white Americans that just don't fly in other communities. And we can't say one way is better than the other, but we can say one way is better for this community than the other.
Absolutely. I love that distinction, right? It's not about what's best, but what's best for so-and-so, or what's best for this group in this community.
Yeah, exactly.
Yeah, I'm seeing this other question about the identified priorities. So the 3 identified priorities were mental health supports, healthcare and accommodations, as well as addressing the gender inequalities. I'm seeing a question here regarding mental health as a priority. If there's any research being done on the impact of certain interventions on autistic people's mental health. I believe this is a clinician who's had adult autistic patients who have expressed some suicidal ideation and cited certain interventions or therapies that targeted goals that were actually not neurodivergent affirming. Any thoughts on that, Dr. Shore, and how we as practitioners can support our patients?
There's so much we need to learn, and we're just beginning to scratch the surface. And the very first step in this type of research is to identify the questions, which you just presented a very good question. We'll be hopefully answering a tiny piece of that question with the suicide prevention grant, where we're going to compare 2 different interventions, brief interventions. And again, probably I would guess that we're going to end up with results that may say this may be better for this group and this other approach may be better for that other group, but I don't know. We'll find out.
So stay tuned.
Yes.
we'll be waiting to hear that. But I really appreciate myself as a clinician and a researcher having some of those decision trees of if you're working with this or you're trying to look for this question and this answer, how to formulate the work that we do. So I think that I'm not alone in thinking that I love having options and being able to decide to guide my decision making. How about, I love this question here. What is the role of the family in facilitating participatory research in addition to working with self-advocates and autistic adults? Dr. Shore, any additional comments on the role of the family?
Well, I would say the role of the family is very important, and it's a big role. And depending upon the type of research that can be done, it may be supporting the person, the autistic or whatever the community is, person, in engaging in that research. It may be providing transportation, maybe financial support, maybe another type of support that could be provided through the family. And participatory research could also involve the family. It depends on what the subject is. What is the role of the family in supporting participatory research? Let me know if anybody needs a dissertation topic.
I love that. That's a great idea. Excellent. Let's see here. I'm seeing another question from a grant reviewer stating that there's a disconnect between what researchers should do for participatory research, right? As outlined in Dr. Shore's talk, really the priorities are mental health, healthcare and accommodations, gender inequalities based on this data. But Dr. Shore, you did preface that maybe if working in different settings, that the results may have been different. But this audience member is asking, how do I explain to perhaps genetics researchers or basic science researchers why they need to incorporate participation from the autistic community?
Well, to find out, well, with genetic researchers have a reputation for seeking cure of autism. What I would like to see is, wouldn't it be great if genetic research focused on possibly, if the genetic research could focus on identifying autism in a fetus, turning away from the default of, well, we got to do something about this fetus and make some very unpleasant decisions, to you've got 5 more months to your pregnancy. Let's look at how you can support your child, who it looks like they have a high probability of being autistic, but not necessarily. And we can generalize this for any condition, Down syndrome, which is, we know this genetic research for. And what if the attitude was more towards, we now have a certain number of months to prepare the parents to support their child, who likely has a greater chance of having Down syndrome, and likewise with autism or whatever the condition is. But I've never seen genetic research go in that direction.
And it's very interesting to think about it that way.
Yeah.
And I think having attended, and I believe you were there in May as well, Dr. Shore, at this year's INSAR in Stockholm.
Oh, yes.
There were a lot of wonderful and very fascinating and intriguing conversations on, the integration of autistic voices into basic science research and
Right.
what we do moving forward. I just was really blown away by the depth of those discussions and thinking about what are the priorities and what are the goals really in the work that we're doing. And so I don't know if you had any additional comments based on the talks that you had attended from this May's conference, things that might be related here.
Well, one thing that I was really impressed with is the relative autistic friendly nature of last year's, I guess it's still in this year anyways, the previous INSAR conference. And there seemed to be a lot of effort to accommodate for and make adjustments for autistic individuals, even to the point of having the quiet room be fairly accessible, as opposed to being way off in a corner somewhere where you probably spend 10 or 15 minutes getting there, but being pretty close to the action, but isolated enough so that you really could have quiet. So I found that very impressive.
Me too. And I think I even noticed over the course of the couple of days of the conference, even how we had clapped at the end of talks. It transitioned from regular, or how we typically clap in an audience, to really signing and being very mindful of those in our audience. And so I was very struck by how in the span of 3 days we are able to incorporate that feedback into how we're engaging with others and presenting our content.
Right. Yeah. So I look forward to next year's INSAR in Melbourne.
Me too. I will see you there. All right. I am noticing time. Although I'm sure we could sit here and talk for ages, and there are so many other questions into the chat. But I know that we are short on time, but we are so grateful for everyone for being here with us today. And what an honor for us to have Drs. Doug Russell and Olivia Rayner with us for our inaugural Dr. Andrew Russell Memorial Lecture. Olivia and Doug, feel free, you can turn your cameras on and say hello to our audience again. Thank you again to our speaker, Dr. Stephen Shore, for your work and for presenting to the Tarjan community. And a reminder to our audience to please complete our evaluation survey. We look forward to seeing everyone during this year's Distinguished Lecture Series. We're off to a fantastic start, as well as our very first UCLA Tarjan Center Forum in Neurodevelopmental Disabilities, which will be on Friday, October 13th. I'm looking forward to this year, everyone, and I will see you all next month. Thank you, everyone.
Thank you.
Thank you.